So good evening, everyone. A warm welcome to our Tuesday webinar from the Department of Critical Care Medicine, Yashoda Hospitals. We bring forth these sessions almost more than 3.5 years. Dr. Venkatraman Kola sir is there. So sir is the mastermind behind this. So we regularly do because of his driving motivation with us. So today, for today's webinar, there are exceptional expert panelists. Of course, we have nephrologists, intensivists, biochemists with us to dive into this topic because this topic requires multiple expert insights and views. It itself is a complex thing and it is a physiological, basically a topic which is very, very important, especially from the critical care perspective. Day in, day out, we deal with these problems. So it's nothing but the complex acid-base balances. So when we look at ABG, it's not only the numbers, the interpretation is very, very important. So most of the times day practice, what happens is loosely used terms like the acidosis there. But when we look at whether it's metabolic or respiratory acidosis, it is very important. Most of the times, the younger generation, younger students coming into practice, they may not be able to interpret that easily. And interpreting simple acid-base disorders may be straightforward, but when we go into depths, because these patients will be having associated multiple organ dysfunctions, so many compensatory mechanisms will be kicking in, complicating the scenario. That is the reason I think dealing with these complex problems are also very important because the interventions what we take may depend upon that interpretation. So that important this topic is. So without much delay, I will introduce our expert panelists who are exceptional in their fields. I welcome Dr. Rajasekara Chakravarthi sir. Sir is consultant nephrologist, clinical director and HOD of nephrology and transplant services at Yashoda Hospitals, Hitec City. Sir is having vast experience. As everybody know, it's a very well known, popular name, sir. So CRRT and all, he had done a very good work. And I welcome you, sir, on board. And I welcome Dr. Kiran sir, is a senior nephrologist at Yashoda Hospitals, Malakpet. Sir is having vast experience, especially day in, day out. We discuss with sir the important aspects of the patient. Most of the times, what we think it may change upon discussion with sir. And sir also has done lot of transplants. He dealt with those patients post-operatively also with complex problems and even poisonings here at our center. I welcome you, sir. So we have with another panelist, Dr. Bhavya, yes, Bhavya Sirivelu. She is an assistant professor, Department of Biochemistry at Nizam's Institute of Medical Sciences. Just 2 days back, we interacted. So had a very good session there at Secunderabad, especially regarding all these complex problems. So I welcome you on board, ma'am.
Thank you, sir.
And we have intensivist perspective, of course. Dr. K.C. Mishra sir is very renowned, everybody know. So from Yashoda Hospitals, Somajigoda, sir is having vast experience and very good academician. I think sir's insights will they will be very helpful and valuable. I welcome you, sir.
Thank you, Kaladhar. I think not that very renowned, but doing this kind of webinar, maybe in future will become more renowned.
No, sir. From Somajigoda, you are very, very renowned. I think so much work has gone in, no doubt about it. So I welcome Dr. Harish, the consultant critical care from Yashoda Hospital, Secunderabad. Is post DM from AIMS. I think is going to speak on this topic. So which will definitely start the introduction with that. So without much delay, probably we will dive into the topic. Dr. Harish, I think you can start speaking on this. Thank you.
Yeah, thank you, sir. Yeah, good evening, all. First of all, I would like to thank Venkatraman Kola sir and Kaladhar sir for giving me this opportunity to present the topic which is the most common and very under-evaluated acid-base disorder. that is mixed acid base disorder. So please, next slide. I'm not able. Yeah, coming to the introduction part. So as we all know that the acid-base disorders affect the pH and homeostasis in the body, and these acid-base disorders helps us in decoding the underlying pathophysiology of the patient. And we classify them into primary metabolic and respiratory acidosis and alkalosis. And in ICU patients, in our day-to-day practice, we see a lot of mixed patterns. Like there are more than one primary underlying acid-base disorder that makes the disorder mixed. So this is very commonly seen in critically ill patients due to complex pathophysiology. So, and whenever you look at the ABG, if the pH is normal, that doesn't mean that the patient is normal, and you cannot say that there is no acid-base disorder. So there is a possibility of multiple hidden acid-base disorders. Those are called mixed acid-base disorders, even with normal pH, even with sometimes normal PCO2 and normal bicarbonate levels also. So how do we suspect these kind of mixed acid-base disorders? Next. So we have some set of clues or red flags to the presence of mixed acid-base disorders. So as we all know that the bicarbonate and the carbon dioxide goes in the same direction. For example, if the patient is having metabolic acidosis, where the pH and the bicarbonate levels are low, and the CO2 also goes in the same direction. The CO2 will decrease to compensate as a compensatory process. This is the metabolic acidosis along with respiratory alkalosis to make the pH normal. If the serum bicarbonate and the PCO2 goes in the opposite direction, then you can suspect that there is a mixed acid-base disorder which is underlying. And whenever there is a disparity between the change in pH, change in the PCO2, change in the bicarbonate, when you apply the compensatory formulas, that is also one of the clues to the presence of mixed acid-base disorder. And there is also an increase in anion gap despite the normal acid-base status. So sometimes we look at our ABG looks completely normal with normal pH, normal bicarbonate, and normal PCO2, but sometimes we'll see there is some increased anion gap. So that also shows that there is a mixed component that makes the ABG complex. And acid-base parameters sometimes near normal despite the presence of clinical condition that expected to produce acid-base disorder. So these all are clues to the presence of mixed acid-base disorders. So how do we suspect so to confirm, we use a systematic approach for the diagnosis of mixed acid-base disorders. Next slide, please. So as a general approach for the diagnosis of acid-base disorders, so we'll check at the, first we'll look at the pH, whether it is acidemia or alkalemia. After that, based on the PCO2 and bicarbonate, we'll divide into metabolic or respiratory acidosis or alkalosis, and after that we'll apply some compensatory formulas. And if the compensation is not matching, or if there is any mismatch after applying the compensation formulas, then we can suspect that there is a mixed acid-base disorder. And to diagnose the mixed acid-base disorder, we have some key tools. One is anion gap, and second one is delta ratio. Next slide. So let's revise some of the key compensatory formulas for the diagnosis of acid-base disorder. So for the metabolic acidosis, the pH and the bicarbonate is low, so the expected PaCO2 also will be decreased as a compensatory process. So the delta PCO2 is 1.2 times the change in bicarbonate. So for the metabolic alkalosis, the expected PaCO2, that is when the bicarbonate is high, the PaCO2 will also increased. So the change in the PaCO2 is equal to 0.7 times the change in the bicarbonate. And for the respiratory acidosis, there is acute and chronic compensation. So acute compensation is the change in the bicarbonate is 0.1 times the change in PaCO2. And for the chronic respiratory acidosis, the change in the bicarbonate, delta bicarbonate, is equal to 0.4 times the change in the PCO2. Like that, we have respiratory alkalosis compensation formulas also. For the acute, it is around 0.2 times the change in PaCO2, and for the chronic, it is 0.4 to 0.5 times the change in PaCO2. Next. So we have some Winter's formula also for the metabolic acidosis, that is 1.5 times the bicarbonate plus 8 plus or minus 2. And also, as I told earlier, so we have some important tools for the diagnosis of mixed acid base disorders. So one is anion gap. So anion gap, as we all know, that anion gap is calculated by subtracting chloride and bicarbonate from the sodium. So sodium minus chloride and bicarbonate. So whenever there is a hypoalbuminemia, so as albumin is one of the negative unmeasured anion, so the when you calculate the anion gap in case of hypoalbuminemia, you will get falsely low anion gap. So the corrected anion gap will be anion gap plus 2.5 times the delta albumin, like normal albumin 4 minus current albumin. And also applying the delta ratio is also helpful in the diagnosis of mixed acid base disorders. So delta ratio is calculated by anion gap minus normal value, that is 12, divided by 24 minus current bicarbonate levels. So based on the delta ratio, if it is less than 0.4, it is called pure normal anion gap metabolic acidosis. If it is between 0.4 to 0.8, then it is a normal anion gap as well as combined high anion gap metabolic acidosis. If the value is between 0.8 to 2, then it is pure HAGMA, that is high anion gap metabolic acidosis. If it is more than 2, then there is a superimposed metabolic alkalosis along with metabolic acidosis. Yeah, next one. So we have different patterns of mixed disorders. So starting based on the change in PaCO2 and change in the bicarb and change in the anion gap. So we have a different set of mixed disorders. So I will discuss one by one with the examples. The next slide. So we have next one. Can I get access to move my slides?
I think you can ask them.
Yeah. Yeah, okay. So with the examples, for example, if the patient is in cardiopulmonary arrest and we took the ABG, so we see there is a respiratory acidosis along with metabolic acidosis, where the pH is affected and the bicarbonate is also affected, then the PCO2 is also affected. This is very easily we can interpret this kind of mixed disorders. But sometimes the pH may be normal with a change in bicarbonate and PaCO2. For example, in case of salicylate overdose, where there is a respiratory stimulation, so that leads to respiratory alkalosis and along with high anion gap metabolic acidosis. So there is a combination of metabolic acidosis and respiratory alkalosis that makes the pH normal with abnormal PaCO2 and the bicarb. Like that, when patients with a COPD with and the same patient is on diuretic therapy are coming with multiple recurrent episodes of vomiting, so we see the respiratory acidosis because of COPD along with metabolic alkalosis due to diuretic therapy or vomiting. So also that makes the pH normal and with abnormal PaCO2 and the bicarbonate. And sometimes, which is very tricky, the pH may be normal and the PaCO2, bicarbonate, everything will be normal. But whenever you look at the ketones levels or lactate levels, there is a lactic increased in lactates and ketones. So if the patients with decade diabetic ketoacidosis or lactic acidosis due to some drug and having recurrent vomitings, where there is a high anion gap metabolic acidosis along with metabolic alkalosis due to recurrent vomiting, that makes the pH and PCO2 and the bicarbonate, everything will be normal. and with some set of diseases, some set of mixed diseases. So we can able to see some triple disorders also, along with high ion gap metabolic acidosis, alkalosis with some respiratory component. Next slide. So now we'll start with the case, different cases. So here we have a 14 years girl with bulimia is brought to ER after being found unresponsive at home with an empty pill bottle nearby. So if you look at the ABG, the pH is 7.39 and the PaCO2 is 22 and the bicarbonate is 13. Next slide. Next one. So if you go by systematic approach, the pH is normal here, and the PaCO2 is low, that is respiratory alkalosis, and the metabolic acidosis. So if you apply the compensatory formula for the metabolic acidosis, if you apply Winter's formula, the expected value should be around 23.5 to 31.5. But here the actual PaCO2 is less than the expected value. So there is an underlying respiratory alkalosis also, along with metabolic acidosis. And if you calculate the anion gap, it is 139 minus 88 chloride and 13 bicarbonate. So that is 38. This shows there is a elevated gap metabolic acidosis. And if after calculating the delta ratio is 26. The change in the anion gap divided by change in the bicarbonate. So 26 by 11 is 2.2. So if the ratio is more than 2, we all know that there is a metabolic alkalosis along with metabolic acidosis. So here we can see triple disorder like respiratory alkalosis and high anion gap metabolic acidosis and metabolic alkalosis. And coming to the next example. So a 32 years female, pregnant female, comes to the ER with 4 days history of non-stop vomiting, and her vitals shows there is a tachycardia and hypotension, and the pH is normal, the PaCO2 is high, and the bicarbonate is also PaCO2 is little bit high, and the bicarbonate is 26. Next slide. Yeah. So here the pH and PaCO2 and the bicarbonate is almost near to normal. So while evaluating the if you and after looking at the anion gap or calculating the anion gap, it is anion gap is 146 minus 92 plus 26, that is 28. This shows there is a elevated anion gap. We don't know whether it is metabolic acidosis or what, because the every parameters is in the normal range. So after that, we'll calculate the delta ratio. Delta ratio is change in the anion gap divided by bicarbonate. So here the anion gap is around 28. 28 minus 12 is 16 divided by 24 minus 26. So which is negative. So 16 by negative minus 2 is equal to minus 8. So this is a tricky case scenario where the pH is normal, PaCO2 is normal, but the anion gap is showing high with the delta ratio is on the negative side. So here and in these conditions, we should look at the clinical scenario. Here the patient is having non-stop vomiting with hypotension. So there is a possibility of lactic acidosis because of the hypotension, and non-stop vomiting leads to metabolic alkalosis. So in this kind of situation, so next slide. So when there is a situations like where there is a elevated anion gap with the negative delta ratio, there is a possibility of high anion gap metabolic acidosis along with metabolic alkalosis that makes the pH normal. So in this case, the HAGMA plus normal metabolic alkalosis is there. Next one. And one more case, 78 years old diabetic admitted with abdominal pain, vomiting, and respiratory distress along with hypotension. And there is slight elevated in there is elevation in the urea levels with some hyponatremia and hyperkalemia, some kind of electrolyte disturbances. And the ABG shows next slide. Next one. Next. Yeah. Here the ABG shows the pH of 7.23 and the PaCO2 of 23 and the bicarbonate of 14. So there is a metabolic acidosis with some kind of compensation. The next one. Sorry, previous one. Yeah. So here the pH is 7.23 and the bicarbonate is 14. So after applying the Winter's formula, the value will be around 1.5 times the bicarbonate plus 8 plus or minus 2. It's not there. So it's the part is missing here. So here the problem is the respiratory compensation is uh, the the compensated the actual PaCO2 is less than the expected value. So there is an underlying respiratory alkalosis, and the anion gap is like 130 minus 94 plus 14, that is 22. So this is called high anion gap metabolic acidosis along with respiratory alkalosis. Next one. So this kind of high anion gap metabolic acidosis along with respiratory alkalosis we see in cases like septic shock and in our daily ICU cases like septic shock with renal failure and some kind of drug overdose, salicylate overdose, congestive heart failure and renal failure. Next slide. And here the 28 years old diabetic patients with respiratory distress and with fatigue and vomiting with diarrhea, and there is a history of outside food consumption, and the ABG shows next one. Yeah, next. Yeah, here the ABG shows the pH is 7.23 with a bicarbonate of 14 and PaCO2 of 23. Here there is a metabolic acidosis and respiratory alkalosis. The expected PaCO2 of, is around 27 to 31. So the expected value is 27 to 31, but the actual PaCO2 is less than the expected value. So there is a respiratory alkalosis along with metabolic acidosis. So which type of metabolic acidosis? The next question. So here we apply anion, we calculate the anion gap. Anion gap is 130 minus chloride is 100. Previous slide. And the bicarbonate is of 14. So the anion gap is 16, and the anion gap of the delta ratio is 16 minus 12, that is 4, divided by 24 minus 14, that is 10. That 4 by 10 is 0.4. So up to 0.4, the according to delta ratio, so it is a normal anion gap acidosis. So here we have a high anion gap metabolic acidosis with respiratory alkalosis with normal anion gap acidosis. So this is called triple disorder. Next one. The last case here, we have a 28 years old diabetic with fever, presented with fever and altered sensorium and shock. The ABG shows the pH of 7.23 and the bicarbonate is of 14 and PaCO2 of 34. Next one. So here we have a metabolic acidosis, and there is no compensation at all. So after applying the compensation formula, it will be around 27 to 31, but the PaCO2 is still on the higher side. So there is a respiratory acidosis along with metabolic acidosis, and so this indicates that there is a and after applying the anion gap also, the anion gap is 16, which is a high anion gap metabolic acidosis. So here, and delta ratio is of 4 by 10, that is 0.4. So again, there is a normal anion gap acidosis along with high anion gap metabolic acidosis, and there is a respiratory acidosis. This is also one of the triple disorder. Next slide. To summarize, normal pH in the ABG doesn't mean that the ABG is completely normal. So always we should apply the compensatory formulas for the diagnosis of mixed disorders, and always use the key tools like anion gap and delta ratio. And mixed disorders are the rule, not the exception. So this is very commonly seen in critically ill patients. So clinical correlation is very, very important while assessing the mixed base acid disorders. Thank you.
Yeah. Thank you, Dr. Harish, for that very good presentation. Even though it is a complex topic, you broke it down with clarity and I can say clinical relevance, because most of the cases you have put with the examples. So I think, yeah, we will go to the panel discussion. So I will, Dr. Bhavya, ma'am, are you there? Yeah.
Yes, sir.
The first question I want to ask, I think there are even in the chat box, the message is being coming. So
Yes, sir.
the physiological rationale, what do you think the different buffer systems in our body and how they affect, and what is the effect of phosphate and albumin that we have to take into account while calculating anion gap? Your
Sir.
views?
Sir, it's not new for you, but there are three buffer systems as we know. One, the bicarbonate buffer, the protein buffer, and the phosphate buffer. But the functions of these three affect based on the system in which you are evaluating. Like we know, bicarbonate buffer is mainly the extracellular buffer, and it is related to the lungs and the renal system, right? Albumin mainly is the main anion in the blood plasma, while the phosphate buffer is mainly in the intracellular buffer and it is affected by any renal pathologies, right? So when we are, how does this affect our ABG interpretation is the albumin mainly when you see, sir also has shown this corrected anion gap actually. The albumin being a main negative charged ion in the plasma in a large quantity, it contributes to the anion gap. So when there is hypoalbuminemia, this anion gap is actually gets masked. So we have to see corrected anion gap when the albumin is low, which as sir showed, he has shown a formula that corrected anion gap is measured anion gap plus 2.5 into 4 minus observed albumin, 4 being the normal albumin levels as considered in our population, right? Similarly, for phosphate buffer, though it is not a major ion, but its retention will definitely affect the anion gap, like in cases of renal failure or wherever you see phosphate retention. So especially when we are interpreting the anion gap, this albumin and phosphate will come into action. So we have to see those while interpreting because they are not visible in your ABG report. You have to interpret with the lab report considering the albumin and phosphate also while you are looking at the anion gap in any acidosis.
Yes, ma'am. So
Sir.
what basically ma'am said is if there is the anion gap is calculated as 12 and there is albumin of 2, basically if there is a the normal value what we see as a 4, so 2 drop is there. So 1 gram per deciliter of albumin drop, we have to add 2.5 to the anion gap. Probably in this scenario, if there is 2 gram per deciliter drop, probably it amounts to 12 plus 5, around 17 anion gap. Even though it looks like normal anion gap, but it is anion gap metabolic acidosis.
Yes,
so
sir.
that is how we have to take albumin into account while calculating the anion gap. Yeah.
The other way around, for every 1 gram decrease in the albumin, you can consider a drop in anion gap by 2 milliequivalents per liter. So it's just when you see the report of the albumin, if it's less than 4 by 1 gram, your anion gap will be lessened by 2, masked by 2 points.
Yes.
So you can add 2 points for just a rough interpretation of the anion gap. For every 1 gram decrease in albumin, you add 2 points of anion gap.
Yeah. Yes, ma'am. So, yeah, another question, ma'am. Generally, what we look at in ABG is the lactic acidosis. The moment any patient comes, especially patients who are in shock, to guide our fluid resuscitation, what is happening to the lactate guided resuscitation. So, is there any difference between L-lactate versus D-lactate and how to go about it?
Sure. Thank you for that question again, sir. L and D, maybe you all had gone through biochemistry very long ago. So that L and D are actually stereo isomers of the same lactate form, sir. So why they are getting into importance in ABG interpretation is there are recent concerns about D-lactic acidosis also, which is usually not seen in significant amounts in the human. It is usually of bacterial or microorganismal origin. So in our body, it is produced in very minimal amounts in micromoles compared to the L-lactate. Okay, now when does it come into importance is during ileal surgeries or any gut surgeries where you see perforations, or with the use of now all these prebiotic drinks and the fermented foods, the D-lactate from the microorganisms in the body is increasing. Now the problem comes where, because we have the metabolism of D-lactate in our body is very less. It is not sent out usually as fast as the L-lactate, because the major enzyme in our body is LLDH, which metabolizes the lactate. Okay. Now coming to the interpretation of lactate in the ABG, whether it is the lab or the ABG analyzers or any POCT device that does the lactate, it does this estimates by an enzymatic method, and the enzyme is an L-lactate dehydrogenase. Okay, so whatever the analyzers are estimating is actually L-lactate. It is not D-lactate. D-lactate estimation has very different techniques which are not in common use. Okay, so then when to suspect D-lactic acidosis? If the lactate in the ABG is normal, but you're seeing a high anion gap. That means there is a normal lactotic and normal ketotic high anion gap metabolic acidosis. You have to consider, or you have to pitch in also D-lactic acidosis and ask the patient, or interpret the patient according to this based on his presentation.
So we can do D-lactate levels in the lab, ma'am?
No, sir. No.
No, ma'am. We
No,
can.
they're not commonly available, sir.
Okay.
You can only expect, but you can't
We
estimate.
cannot measure
No.
D-lactate level.
No, sir.
So the clinical context will be like, if you are not able to explain probably acidosis in the background of gut surgery and all, a lot
Yes,
of
sir.
this
Yes, sir.
contributing lactates are not much elevated. Probably we can think of it as a D-lactic acidosis.
And the presentation is more neurological in D-lactic acidosis than L-lactic acidosis. It's very different also presentation.
Yeah. Yes, yes. So next question is Dr. Mishra sir. Mishra sir.
Yeah.
So basically what we use as a ABG analysis, most of the times it is Henderson-Hasselbalch, of course. Very few of the occasions we generally employ using Stewart's hypothesis, or Stewart's strong ion difference. What do you think, sir, between both of them? Is there any clinical scenario you want to use strong ion difference, or what do you think is the methodology that you want to go ahead?
Yeah, thank you, Dr. Kaladhar. No, basically, if you see, we are like from maybe MBBS or post-graduation time, we are doing mostly the bicarbonate way of interpreting ABG. And where we check mainly carbon dioxide and bicarbonate. Whereas in Stewart approach, this is the newer one, but unfortunately, it is not that widely, what do you say, like practiced. In that case, if you see the main things, what they see is like strong ions. Strong ions are like sodium and up to some level potassium and chloride and carbon dioxide and weak acids like your albumin, phosphates and all those things, which comes in the weak acid. So strong ion difference, visually if you see sodium is around 140, if you take chloride around 100, the difference will be around 40. That is what actually the sodium and chloride will decide about your bicarbonate level. Per se, they didn't see the H plus and bicarbonate there. The strong ion difference will decide about your bicarbonate and pH of a different disorders. So when if the strong ion, let's say sodium minus chloride, which comes to around 40, if it is less, then we need to think in terms of some form of acidosis is there. If it is beyond 40, we should think in terms of some form of alkalosis. So it is not widely practiced, but in some conditions where, let's say in a case of hyperchloremic metabolic acidosis, that is a condition where we cannot explain by our normal bicarbonate theory of checking the ABG. In these cases are complex cases where we cannot interpret an ABG on the basis of your bicarbonate way of doing ABG. In those cases, Stewart approach really gives an idea. Let's say in hyperchloremic metabolic acidosis, where the chloride will be higher. Let's say sodium is 150, chloride is 120. In these cases, if you see the difference in the strong ion, 150 minus 120 will be around 30, which is less than 40, goes in favor of acidosis. In this, some scenarios where Stewart approach is the only way we can explain a complex acid-base disorder, which is very, very difficult to explain with your normal bicarbonate way of doing ABG evaluations. But yes, in complex disorders, Stewart approach may help us, but still because we are like practicing our bicarbonate way of doing ABG for very, very long time and there it is much more easier, and we are very much into it. I think we should continue with bicarbonate, but still Stewart approach, we all should understand and have some idea about the strong ion difference and weak acids and all. A thought is the weak acid HA plus and HA minus, and strong ions. So this may help in at least in complex disorders where we cannot explain it by your bicarbonate theory.
Yes, sir.
I hope
Thank you
it
very much,
answers
sir,
the
for
question.
that. Yes, sir. Yes, sir. Thank you very much, sir. It is a very good insight, definitely. But as you said, like and Anderson Hasselbalch gives a speed, and definitely it's more practical and easy to calculate compared to Stewart. But certain scenarios, as you said, in where there are multiple mechanisms in play, probably a Stewart approach may help in differentiating between because of based on the strong ion difference, it can differentiate between different disorders. Thank you, sir. So I think we'll take the views from Dr. Shishkiran, sir. Shishi, sir? Yeah, yes, sir. As explained by Dr. Harish about the gaps, especially anion gap, and then breaking it down to the delta ratio, where you may see the patients may look like having an anion gap, but when we look at delta ratio, the patient may be having underlying normal anion gap, and otherwise sometimes patients having hyperchloremia, then normal anion gap. So there are many complex disorders that will be playing to contribute to this normal anion gap metabolic acidosis. So what do you think, sir, when there is a normal anion gap metabolic acidosis, how to approach to that? And especially regarding the point of renal tubular acidosis, can you explain in detail about how to approach to those disorders?
Let me first congratulate Dr. Harish for giving such a wonderful insight into this. I have learned a lot by being part of this session, and also I thank Aladar for including me into this. Now, coming to this question part regarding renal tubular acidosis, this is something which we commonly see in nephrology practice. We are mostly interested about distal renal tubular acidosis and proximal renal tubular acidosis. Type 4 we see, but we are not very much interested about it. As far as type 1, that is distal, and type 2, which is proximal, the simple way of looking at it is by looking at the urinary pH. If pH is more than 5.5, mostly goes in favor of distal renal tubular acidosis. If the urinary pH is less than 5.5, it goes mostly in favor of proximal renal tubular acidosis, because the pathophysiology, for the sake of people who are there, in distal renal tubular acidosis, it is a defect in the excretion of hydrogen into the urine. So since the hydrogen is less, the pH is always more than 5.5. Whereas in the proximal, it is because of the defective absorption of bicarbonate in the proximal tubule. So here the pH can come down. But the trick is sometimes we may not get nascent cases. We may get cases where patients who are partially treated here and there. They have taken something and we are not sure what they have. In those scenarios, what we can do is we can do a bicarbonate loading. Suppose if the pH is borderline like 5.3 or 5, we are not sure whether it is distal or proximal, we can give a bicarbonate load. Suppose if we give a bicarbonate load and the pH, urinary pH starts increasing and goes beyond 7, then we are sure it is a proximal renal tubular acidosis, because whatever bicarb we are being given, it is overwhelming the absorption capacity of the proximal tubule. So everything is going out. So the pH of urine, which was for less than 5.5 or around 5.5, starts increasing. Whereas if it is a distal renal tubular acidosis, here if we give a bicarb, nothing much will happen, because here the proximal absorption capacity of bicarb is intact. So here the pH will be 5.5, but it will not worsen beyond that. So, or we can do something like a fractional excretion of bicarbonate in this scenario. But the easiest one is what I have said. By this, we can make out whether it is a distal renal tubular acidosis or a proximal renal tubular acidosis that we are encountering.
Yes, sir. Thank you, sir. So
other clinical picture also we can look into, like hypokalemia will be there. In proximal, in distal renal tubular acidosis, we can have calculi in the kidney. In proximal renal tubular acidosis, we can have a Fanconi-like picture. So other clinical associated symptomatology also will help us what we are doing.
Yes, sir. So regarding type 4 RTS, sir, do you think aldosterone measurement and all have to be done, or most of the times it's clinically based on ABG, we can diagnose and just leave it there?
Most of the times in type 4 distal renal tubular acidosis, it is hyperkalemia, which is there in a patient with diabetes who has got acidosis. In day-to-day clinical practice, we are not looking into serum aldosterone level or anything. What we are trying to give fludrocortisone for these patients. In fludrocortisone, by giving fludrocortisone, we can, because most of the distal renal tubular acidosis most of the type 4 renal tubular acidosis is because of hypoaldosteronism. Here, the excretion of potassium is reabsorption of potassium is impaired. So excretion of potassium is impaired. So hyperkalemia will be present in those scenarios. So if we, in such scenarios, if we give fludrocortisone, we can get a clinical correction in these cases. Most of the times, the aldosterone estimation we are not doing in day-to-day practice.
So mostly dietary potassium restriction and fludrocortisone may help to tackle the situation.
Dietary potassium restriction and fludrocortisone, most importantly, it will help in correcting these scenarios.
So the point of view, like especially the metabolic alkalosis point of view, most of the times we concentrate on acidosis, metabolic acidosis. Acidosis means generally it makes us restless rather than metabolic alkalosis, most of the times ignored one. So what do you think, sir? How is your approach? Any patient with having a metabolic alkalosis, most of the time more than 7.5 pH and all, what is your approach, sir, regarding that?
Most of the times, metabolic alkalosis we are seeing in cases of patients with hypertension. We are looking at Kahn syndrome, such sort of scenarios. Or the second thing is whenever the patient is being treated with some drugs, especially diuretics, they cause metabolic alkalosis in these scenarios. And patients with nephrotic syndrome, lot of protein loss. These patients also, they have this loss of protein and protein-bound buffers. So they also have got metabolic alkalosis in the nephrology practice. These are the common scenarios. Kahn syndrome is one scenario where we frequently find metabolic alkalosis, hypertension, and hypokalemia in these patients. And nephrotic syndrome patients are the other ones whom we see. And patients who are already being given a lot of diuretics, especially loop diuretics.
Yes, sir. Yes, sir. Most of the times we have to divide between whether it's chloride responsive or chloride unresponsive, sir. That is, you give a saline challenge for some time and then look at whether metabolic alkalosis is getting better or not.
Yes, that is something which is important. Once we give chloride, if it is getting better, then it is a chloride responsive metabolic alkalosis. Most of the times hyperchloremia causes acidosis, so it causes this infusion will be something which is negating it.
Negating metabolic alkalosis, yes. And Mishra sir, basically regarding triple acid-base disorders. So most of the times what happens, we don't go behind looking at maybe mixed disorders. We look at respiratory alkalosis, but metabolic acidosis. Sometimes when we dissect them down, looking at anion gap and then delta ratio, then we will find out that there is a associated another triple disorder is also in play. So anyway, I think some were discussed by Dr. Harish. Can you tell as an overview how to approach to these disorders, and when you is there any different management when we find out a triple acid-base disorder? Your insights on that, sir.
It is, I think the most important part is in ICU, when we have like complicated cases with multiple organ or system involvement, and these people can have diarrhea, these people can have significant vomitings, or patient can have a Rayleigh tube aspiration for a prolonged period of time. with a sepsis and maybe a COPD patient. These are the cases where if you see a pH which is towards normal side with some abnormality in the carbon dioxide and bicarbonate, that means this patient must be having some triple acid base disorder. I think Dr. Harish has told nicely how to go about, see, one after one, how like delta anion gap, then delta bicarb, then delta ratio. I think for every ABG in ICU, we should check stepwise, like including the validity also. So we start with validity because sometimes when the ABG is looking very much normal or grossly abnormal, then you should start with the validity. It is again important to see the validity by simple Anderson-Hasselbalch equation. We can know the validity of ABG, then go stepwise. So in that case, we can see a lot of, believe me, if you go deep and stepwise in ABG evaluation, you will see a lot of mixed acid-base disorder. So see, like a patient cannot have respiratory acidosis and alkalosis same time because one patient cannot hyperventilate and hypoventilate in same time. But the patient can have metabolic acidosis, that to high anion gap, normal anion gap, that to normal anion gap. Metabolic acidosis is more common in patients who are having, let's see, 2-3 conditions where we should always think of look at the history also, which can guide you what might be the possible disorder. Let's say somebody is having continuous diarrhea, they will lose a lot of bicarbonate. That itself can normal anion gap metabolic acidosis. Patient having vomitings, patient having relative aspiration, or they are told like renal tubular acidosis. These are the few cases where we need to think in terms of a normal anion gap metabolic acidosis apart from a high anion gap metabolic acidosis when your anion gap is high. Some in we believe like metabolic volume contracted patient, let's say somebody is on diuretics for a prolonged time and maybe AKI or something, patient might be having metabolic acidosis because of diuretic use volume contracts. These people can have metabolic alkalosis also. So it is kind of a mandatory in an ICU where your pH is required is towards normal side and your bicarbonate or maybe PCO2 compensatory mechanism, whatever compensatory the formulas we are using is not fitting into, then these people will have some triple acid base disorder. And sometime, let's see, we should not land start giving like metabolic acidosis or there is a metabolic alkalosis. We should see before giving bicarb or something which is only a symptomatic treatment. So it is very important to go stepwise approach when it comes to like evaluating an ABG. By doing that stepwise approach without missing anything, and more so when delta anion gap and delta bicarb gap and delta ratio, we will see a lot of mixed acid base disorder, which we miss by just looking at your ABG, the pH, PCO2 and bicarb. So every step need to be taken seriously, and in a ICU setup where patients are very sick with multiple issues going on, acid base disorder, that too mixed acid base disorder is very, very common.
Yes, sir. I think among mixed acid, Shashi sir, yeah, please.
Like generally this chloride thing, which you asked as far as metabolic alkalosis is concerned, we generally use that for evaluation of hypokalemias. So generally urinary chlorides which are less than 20, more than 20 is the cutoff we generally take. Suppose if alkalosis is there and it is less than 20, then we look more in terms of diuretic or anything like that, which they have taken, or if there is any vomiting or something like that. But if the chloride is more than, urinary chloride is more than 20, the another thing what we look in evaluation of hypokalemia is with metabolic alkalosis is to see if they have hypertension or not. That is the second step that we look into. With the hypertension, as I have told, Kahn syndrome or secondary hyperaldosteronism or anything that we look into. Or if there is no hypertension, again, we have to look into these mostly in pediatric cases like Bartter syndrome or these things it will come into. So mostly in pediatric Barters or something, metabolic alkalosis, more chloride in urine, and then no hypotension or normal blood pressure. So it goes into that. But real clinical scenarios, most of the times, metabolic alkalosis, more chloride in urine, hypertension, Kahn syndrome is what day to day we see most of the times.
Yes, sir. Thank you, sir. So, Mr. Sir, the next question goes like, suppose if there is a mixed acidosis, especially this is a difficult to treat. There is a respiratory acidosis and there is a metabolic acidosis. Assume like a patient who is having severe ARDS, as lung is so compromised and there is a hemodynamic instability. So because of severe ARDS, there may be retention of the CO2 and along with shock, probably involvement of like AKE and all, the possibility of metabolic acidosis sets in. And then probably here, the important thing, lung protection, lung protective ventilation, where we have to use low tidal volumes. So this type of scenario definitely becomes a challenge to critical care physician, and of course, most of the time we resort to early RRT in these patients. But what do you think is the approach from your point of view, sir?
Very interesting question, Dr. Kaladhar. Before going to your question, like I just want to answer something which is very, very important, which is more relevant in an ICUs. See, lot of time you will see cases coming from ER, will let's say severe sepsis patient with septic shock. They will have severe metabolic acidosis, and maybe their pH will be in the range of 7.2, 7.3. Their bicarb will be in the range of 5, 10. Let's say they're diabetic ketoacidosis patient also. The severe acidosis will be there. And these people are compensating by respiratory wise. If you see their carbon dioxide levels will be in the range of 10, 11, 12 like that. And their pH is maintained around 7.2, 7.3. And because of acidosis or maybe shock and all those things, in this kind of cases, what I've seen many times, what our maybe juniors and maybe in emergency department, one gross mistake what they do. This kind of situation, after intubating these cases, what they do is they just ventilate them with a normal way of ventilation. Let's say they keep a tidal volume around like 6 to 8 ml per kg, something around 400. They keep a respiratory rate of around 18, 20. But before that, the patient was hyperventilating. The patient was breathing at a rate of 35, 40. And because of that, he was able to like wash out carbon dioxide and maintain a pH of around 7.2 to 7.3. So once you take out that compensation, what the patient was having after paralyzing and intubating them and ventilating at a rate of 15, 14 or 18 or 20, their PCO2 will increase. It will not increase to like higher side. It will just increase from maybe 10, 12 to 30 or 35. The pH will drop from 7.1 to 6.9, 7 and all those things. And these people can have cardiac arrest because of severe acidosis. This is one of the common mistake what I see mostly done maybe in emergency department or somebody who is not that and they are intubating these cases. So just by decreasing that humans, like persons drive of washing out carbon dioxide by intubating them, actually we are harming. So first thing in this kind of patient who is like compensating respiratory wise by hyperventilating, let's say a 35 or something, that minute ventilation need to be matched once you intubate a case who is having severe acidosis. This is one of the important thing everyone should understand and should know whenever they are intubating a severe acidosis case. Second thing, coming to your question, let's say in a hypothetical COPD patient having severe ARDS where carbon dioxide is much higher and they might be having severe sepsis also causing a severe metabolic acidosis where the pH will be low. See, if you see the ARDS ventilation strategy, we can allow permissive hypercapnia. But in this kind of situation where severe acidosis and CO2 retention is there and pH is very low, that itself can detrimental to the hemodynamic stability of a patient. If the pH is very low, at least we have to target the pH to be more than 7.2. And in that cases, checking your, like say, plateau pressures and all those things in check, we need to ventilate. Maybe we have to hyperventilate to make sure the pH to be at least beyond 7.2. Sometimes in these cases, we give even in the ARDS net protocol and ARDS protocol also, we give bicarbonate, the pH is less than 7.25. In this particular scenario, I will not go for the permissive hypercapnia. I will try to target a pH at least beyond 7.25 to cause less harm to the patient hemodynamic wise. So we'll try to hyperventilate and maybe by little increase in the tidal volume and increase in the respiratory rate up to 35. A arbitrary number why it has been given, I am not very sure about, but still 35 is the rate what up to which we can go. Maybe we can increase the tidal volume with respect to the plateau pressure. We should not go very high on the plateau pressure and try to come down on the carbon dioxide to maintain a pH beyond 7.25. If it is not happening, this is the situation as per the ARDS protocol also, we may need to think of giving bicarbonate to maintain a pH of beyond 7.25 to at least prevent major hemodynamic instability.
Yes, sir. I think that was a very good point. I think practical point what you made is a patient coming with severe metabolic acidosis and compensating with washing out his CO2. The moment you are intubating this patient because of probably hemodynamic instability, respiratory distress, whatever it may be, most of the common thing where patient having 7 pH and you take out that compensation because of acidosis, there is sudden cardiac arrest. So that is very, very important practical point, I can say. I think very good, sir. Thank you very much. And Dr. Bhavya ma'am, are you there?
Sir, yes, I am here, sir.
Yeah, regarding actually when we look at ABG, we do even get hematocrit, we do even get the creatinine values in some point of care, sometimes bilirubin values. How do you think even like sodium, potassium, sometimes we do, sometimes really if it is standardized, especially with regular the other values other than
Analysis.
analysis. So what do you think is the difference between regular lab values by serum samples or otherwise point of care testing, whether we have to rely upon those values or not?
Sure. Speaking about first the electrolytes, because that is the main reason why we use APG. You know this difference already, that the estimation of electrolytes in the ABG compared to the labs both differ in terms of how the estimation is done by the machine. The labs take only the serum part of the sample and dilute it and estimate the electrolytes in that. While the ABG will not dilute the sample and it directly estimates the electrolytes. So this difference affects when the protein content of the serum taken is larger than expected, the proteins or the lipids, like in paraproteinemia conditions or hypertriglyceridemia conditions. The estimated electrolytes will affect because the content of the plasma occupied by the solids is more in these patients. So this is the effect that we see in the central labs, the bigger analyzers used in the central labs, while that effect is not there in the ABG. So when you have such a patient where these are confounder, you have to rely more on the ABG assessed electrolytes compared to the lab assessed electrolytes. So coming to the bilirubin and creatinine, which are metabolites and not electrolytes and blood gases. See, the utility of ABG in these metabolites is fairly new. That need came up because of the time taken for action should be lessened, because sample sending to a central lab is taking time. Clinicians started relying on the faster results from the ABG machines, which give you immediately, right? Now, the main difference here is one, of course, the sample, whether it is a venous sample, which is sent to the lab, or arterial sample, which is sent to this POCTs, that you have to consider. Apart from that, coming to the methodologies by which these are assessed in the ABG machines compared to the labs, creatinine, it's almost the same method. So you see less discrepancy in the creatinine values between the POCTs and the central labs. Okay. Provided the values are normal or high. Even in the normal ranges, smaller changes in the creatinine are not being detected by the ABGs as per the literature published. That might be due to the calibrations which are differing between the machines, the bigger machines and the smaller machines. While the values are correlating at the above normal and higher levels of creatinine, there has been a discrepancy at the normal levels or low normal levels of creatinine. Okay, this affects when you are interpreting the creatinine in AKI cases, where you need to rely upon the central lab better than the ABG. Coming to bilirubin, like sir was telling, ABGs even give, the POCTs even give hematocrit, right? This hematocrit is actually calculated from the hemoglobin content, which is spectrally measured by the machine. Spectral meaning the light absorbance by the hemoglobin is measured. Okay, so by default, these machines consider the hematocrit to be normal while calculating the bilirubin. Okay, so in conditions where your hemoglobin is affected, like in severe anemias or polycythemias, better rely on the central lab bilirubins than the POCT bilirubins. Also, one more point is the POCTs give only total bilirubin and they do not differentiate between the conjugated and unconjugated bilirubins. So, the need of assessing the patient for which type of bilirubin is what is you're assessing the patient for, first thing. And if there is coexisting hemolysis, which is leading to lower hemoglobins or any polycythemias, you are not, it is not encouraged to use the POCT bilirubins, rather rely on the central lab POCTs. Also, HB variants, I wanted to speak about that also. When there is a hemoglobin variant, and hemoglobin that is not the adult hemoglobin, more in concentration, that also affects the bilirubin estimation and hemoglobin and hematocrit estimation in the POCT devices.
Yes, ma'am. Yeah. Thank you. Thank you very much for that elaborated explanation, ma'am. So generally we look at the ABG values, especially bicarbonate standard value and measured value. So what do you think which has to be taken generally, the difference between those two, ma'am?
So again, the same thing, sir. Bicarbonate is from Henderson-Hasselbalch in the POCTs, while in the lab, the machines measure apart from the bicarbonate, the dissolved carbon dioxide in the plasma also. Okay, and the sample being sent to the lab is a venous sample which contains more carbon dioxide. So there will be a discrepancy in the bicarbonate, which is usually higher given by the central lab compared to your POCT devices, sir.
Okay.
Which
Anything
one we
to
should
add,
take,
Mr.
madam, when it comes to just a small doubt, because Dr. Bhavya is there, I can ask that doubt of mine.
Sir, please.
So actually, when it comes to anion gap,
Sir.
if you see the theory, they say that you should check in the bicarbonate, we should take not the ABG bicarbonate, it should be the bicarbonate from the lab. Is it so? And in
So
that
for
case,
for urine you say, sir? You're
yes,
asking
no,
about urine?
no, anion
No,
gap when we
serum.
check in ABG.
Okay, ABG anion gap. Okay, sir. So the anion gap which have been calculated, or the reference values that have been derived, they used which type of bicarbonate is what comes into picture when you're analyzing it. On the ABG analysis, what anion gap is given is based on the bicarbonate measured in the ABG analyzers in a supposedly normal patient. So if you want to truly assess the anion gap, like your triple, that mixed acid base disorders, better to consider a lab assessed bicarbonate, because that takes into picture also the carbon dioxide dissolved in the blood, sir.
Yes, thank you.
Does that clear your doubt, sir? Anything?
But actually, whatever I've read the theory, it's theory wise, actually the bicarbonate, what we are taking in ABG from the arterial bicarb, which is a calculated one,
Yes,
by
sir.
the Henderson-Hasselbalch equation, may not be holds good. We should
Yes,
check
sir.
a proper lab bicarbonate when we are checking
Yes,
the
sir.
anion. And if we do that, then there will be a lot of changes in our calculation itself.
Yes, sir. True that.
So, yes, ma'am. Thank you. Thank you very much, ma'am. So, one question to Kiran sir. Is there a situation where ion gap is there but without any acidosis? So, what are those situations, sir?
That one thing is paraproteinemias. Sometimes in paraproteinemias and hyperphosphatemias, we can have this high anion gap without any actual disorder.
Acidosis.
So in myeloma patients, these patients, we need to be vigilant about it.
Yes, sir. Probably, I think in some situations, just looking at ABG, we generally, without acidosis, we don't much pay attention. Probably in some situation where this anion gap has to be calculated, where if there is a anion gap and without much acidosis, then it may point towards, as you said, sometimes paraproteinemias or multiple myeloma, especially in the context of AKI patient coming. We do see these patients in ICUs here and there. So thank you, sir. Chakravarthi sir, are you there, sir?
Yes, Kaladhar, I'm here very much. Thank you for the learning.
Sir, we want overall your expert insights, what to...
So, whatever I understood over a period of time and today's discussion, whenever you see a patient, first look at the background status. Is the patient in shock? heart failure, some history of renal failure or diuretic usage, these type of things, please note. Then look at what is the primary acid base disorder and look for what is the compensation. Dr. Harish gave beautifully a list of how much compensation is expected for each of the, and it's available also as a table anywhere. Once you know that, you have to look at what is the metabolic component, that is the anion gap. You will calculate, try to classify them into high anion gap and normal ion gap. By then, most of the times you are able to come up with some sort of a treatment strategy also. I think though some of these patients have complicated mixed ones, we always look at primary, what is the secondary response, which may be corresponding response, or you are looking at a mixed component. So when you look at a mixed component, you will always look at the delta, whatever that he has mentioned. The next step would be look at the osmolar gap. So most of us, at least nephrologists, don't bedside go through this one by one stepwise. But those of you who are spending time next to patient, probably it makes a lot more sense to go 1, 2, 3, 4, 5 steps. And finally, look at the respiratory component. If you are looking at a metabolic acidosis or metabolic alkalosis, this is how I would want to go by. My bias is, after doing all this, we are still in the first 3 steps is when we will decide on treatment strategy or so. The other things may be a little academic and sometimes a little more insight to know something that we are not looking for or we cannot explain, like a poison or something like that. This is my understanding. Thank you.
Venkat sir, your insights, sir, overall, what do you think we have to approach to this disorder?
So I personally feel we should be treating the clinical context. ABC should be a add-on value to it. And as Sir said, what actually the purpose behind this program is, many of the times, the straightforward metabolic acidosis, high NN gap metabolic acidosis, normal NN gap metabolic acidosis, we all sorted out and has been discussed extensively. Most of us in the bedside do it right. But in clinical context, as Dr. Harish and all of our panelists has brought here, we do see pH being normal. You have a varied range of CO2 and bicarbonate in a patient where you need to uncomplicate that underlying 2 or 3 problems, which I think has a clinical context. As Rajasekara sir said, probably for a straightforward cases, they may not be important, but in a clinical context, as we all see, simple diabetic ketoacidotic patient receives a huge amount of saline load. Initially, it looks like a high NN gap metabolic acidosis. Later, you also find a add-on hyperchloremic normal NN gap metabolic acidosis. And if you keep on treating the high NN gap metabolic acidosis without looking at it, your patient will not improve. So I think those are the points which we are trying to find out by all this. As we all said, look at delta gaps and delta ratio, and probably add on to that the other 3 components which we are talking about. And from there, I think you go to the clinical diagnosis. If you don't go to the clinical diagnosis, why it happened? For example, we spoke about the patient had metabolic acidosis, metabolic alkalosis with respiratory also a disorder. You have to find out the reason, clinical reason behind all the 3, so that you have a mechanism to address them and correct the patient and cure the patient's problem. Otherwise, your ABC interpretation without a clinical context will not solve my problem. It is like a PA catheter without giving a result, because you are not interpreting to a extent to make the corrections what are required.
Yes, sir. I think the crux is treat the patient. I think the ABG and other things are add-on. So clinically and otherwise, patient target management is very important.
What I understood is the more and the more you dig into the interpretation of ABC, as Misra said, including the Stewart approach and all, you learn that you understood it less and less. So
this is called Bayer's law. Actually, this is called Bayer's law. What Rajasekara are told. Bayer's law shows that once you are immature, your decisions will be much faster and you will be much faster acting actually when it comes to treating a patient. Once you become more and more like, can't say like practice more, seeing more patients, then you will be educated and knowledgeable and that wisdom will come. That will take more time in treating a case and not a number. I think the final words, whatever has come, these are all the wisdoms.
Thank you.
Yes, sir. I think one point actually regarding osmolality, when we ask for osmolality, because to check the osmolar gap, measured minus calculated osmolality, calculated as we check in 2 into sodium into plus blood urea nitrogen by 2.8 plus glucose by 18. But Dr. Bhavya ma'am, so
Sir,
when we ask lab, they also give calculated osmolality. Do you think the osmometer has to be there to measure the proper osmolar gap?
yes, sir. Osmometer always will be better for capturing all the ions contributing to the osmolality compared to the equipments, because there are some unmeasured ions which are captured by osmometer but not by the analyzers. So always osmometer is superior, and it is of lesser cost investment for the labs also. It is very minimal investment, sir. There is no recurring cost as such.
Is it
So
available with Nizam's Institute, ma'am, right now?
yes, sir. Yes.
So when we check osmolar gap, invariably we have to have a osmometer.
Yes, sir.
Okay, ma'am. Yeah. Thank you. So, Dr. Harish, any final comments from the speaker? Harish, I think you have to unmute. You're on mute.
Sir, actually, the topic is complex ABG acid-base disorder. So, whenever I go through the all the research articles and all, so I found that the pH is normal with abnormal PaCO2 bicarbonate that usually we see in our ICUs. But one thing I found which is very interesting, that the pH is normal, the bicarbonate is also normal, then the PCO2 is normal, but with increased anion gap. So in the theory only, I found that okay, metabolic as some patients with the decay and vomiting, recurrent vomiting, you may have metabolic high anion gap metabolic acidosis along with alkalosis, which makes the pH and PCO2 bicarbonate everything will be normal. So this is the, I think, tricky ABG. So even I never come across in my real time practice, but this I found in the literature.
I think, Harish, that's where clinical context comes. If I have a patient who has a medical disorder and his ABZ looks too good to actually believe. And the other point is, even pH is normal, bicarb is normal, CO2 is normal, measure anion gap. Just because you do, only we do anion gap when there is a metabolic acidosis to see whether it is high anion gap or normal anion gap. Your point takes out that key measure anion gap irrespective of whether there is a metabolic acidosis or not. Because in triple base acid base disorder, these kind of counterbalancing each other can neutralize, and you may have a normal CO2 and bicarbonate in a patient, which is a real-time possibility. And I think the another point, Kaladar, which I wanted to mention, if you take textbook mentioned SOC, textbook mentioned ABC presentations, it is very beautifully mentioned with compensations and all. But in real world, as Dr. Harish pointed out, these kind of complex triple acid based disorders are not uncommon. They are not identified because of our ignorance. That's it. Maybe, as Rajasekara said, many of them may not have a direct management implication, so we don't focus much on that. But they are not uncommon. They are more common than, I think, those which are considered to be a very straightforward one. Because even you take SOC, straightforward one form of SOC is very uncommon. You will have 2 or 3 cardiogenic with hypovolemic, with some vasodilatory septic SOC with overlapping of that. So in real world, in ICU, in critical care, we do see this. And a very valid point raised by Harish, you should be measuring anion gap irrespective of your whether there is acidosis or not.
Sir, I want to discuss one more point also. We in our day-to-day practice, we measure CSF lactate for the diagnosis of meningitis, especially bacterial meningitis, where the levels are, if the levels are more than 3.5 or 4, then there is a high possibility of bacterial meningitis. But some we use bedside ABG for the CSF lactate, but I don't know whether the ABG is calibrated to the CSF. ABG is nothing but just for the blood gas analysis. So can we use it for the CSF, or for
I think
the
Bhavya madam can answer that question.
Yeah.
I think probably we use it.
and what is the correlation actually? That is with
CSF lactate. Can we just put in a CSF in the regular ABG machine and get the lactate and can we interpret it? No? That's what generally we do. So
Sir.
easy standardized to accept that.
Sir, certain manufacturers have standardized their equipment for other body fluids like CSF. If it is not specified for that fluid, it is not calibrated for it. So better not to rely completely on it, sir.
Oh,
The newer models that are coming from the same manufacturers, they are giving for different body fluids. So we have to confirm that first and then rely on
probably
it.
read the monograph and confirm that.
You can ask your lab, sir.
Lab, yeah, can ask the
You
lab.
can,
Yeah, of
you can
course.
use CSF lactates in the lab, right? Lab can
Yes,
get
sir. Yes, sir. Provided the sampling transport is appropriate.
Yes, yes. Thank you. Thank you. Okay, sir. I think very good presentation, Dr. Harish, and I think very clinical insights being shared, a very valuable session, I can say. I think across all like nephrology, intensive care, and biochemistry, especially madam's opinions also invaluable. I thank Dr. Chakravarthi sir, Dr. Kiran sir, Dr. Bhavya ma'am, Dr. K.C. Mishra sir, Dr. Venkatraman Kola sir, Dr. Harish for his very good content on the topic, and it's really a very good session. I think there was almost around 100 people logged in and very good active participation from the delegates also in the chat box. So I thank our Yashoda Hospitals, our digital and branding team also. Thank you very much, one and all, and good night.
Thank you.
Thank you.
Thank you.
Thank you, sir.